Diagnosis of Abnormal Behaviour. Central to the medical model of abnormality is the ability to classify and diagnose mental disorders. The main purpose of a diagnostic system is to enable a suitable program of treatment to be chosen. Kraepelin, 1981, 1896, was the first to propose a system consisting of two major groups of mental diseases. His idea formed the basis of the more complex Diagnostic and Statistical Manual of Mental Disorders, DSM, in use today. It is used mainly in the USA but is referred to in UK training programs for mental health professionals. The manual was first published in 1952 by the American Psychiatric Association, APA. Psychiatrists use the manual when diagnosing mental illness. It contains a description of mental health disorders and their symptoms. The DSM has been periodically updated and psychiatrists are currently using the fourth edition, DSM-IV, which was published in 1994. The earlier versions classified 16 different types of mental disorder. Since the third edition in 1980, factors such as general medical conditions, psychosocial and environmental problems have also been considered, indicating a movement towards combining physical and psychological knowledge and understanding. This is known as the multi-axial classification system. The individual is rated on 5 separate scales, or axes, which broadens the amount of information gathered from the patient during the diagnosis. On Axis 1, the clinical syndromes are considered, apart from personality disorders, which are considered separately. On Axis 2, the personality disorders are considered. The categories have been split in this way to ensure that clinicians do not miss a further problem because they focus solely on the current one. For example, a person may present with a substance abuse problem but also have an antisocial personality disorder. On Axis 3, the clinician should note any general medical conditions that could affect the patient's mental health. For example, if the patient has cancer, this is likely to impact on their psychological well-being. A diagnosis of diabetes might explain why a child has become aggressive, instead of diagnosing a conduct disorder. Treatment given for physical conditions may also affect the way a patient responds to mental health care. Axes 1 to 3 are compulsory when making a diagnosis, whereas the next 2 axes are currently optional. On Axis 4, information about any psychosocial and environmental problems experienced by the patient are considered. For example, problems with housing, access to healthcare, or difficulties within the family. Axis 5 measures the patient's current level of adaptive functioning. The patient is rated on a scale of 1 to 100 for social, psychological and occupational well-being. A score of 90 indicates superior functioning over a wide range of activities. The patient is doing well at work, has good social relationships and is coping psychologically. A score of below 10 would indicate that the patient was in danger of severely hurting others, or had made serious suicide attempts and was functioning very poorly. The inclusion of Axes 4 and 5 reflects movement towards a more interactionist approach to mental health problems. Most psychiatrists now accept that mental health difficulties occur as a result of the interaction between biological, psychological and sociological factors. Previously, diagnosis involved simply classifying a patient in a clinical category, for example, schizophrenia, and prescribing drug treatment. Since 1980, the patient's needs have been assessed more broadly, and they can be referred to other agencies if necessary. For example, if a patient is having difficulty finding a job, there may be work schemes within the community, specializing in helping people with mental health problems. If a patient is having difficulty with childcare, a family social worker might be contacted for assistance and information. A multidisciplinary approach can now be adopted, where professionals from different areas of health and social care work together. Each category in DSM-IV includes a list of symptoms and other information to help diagnosis, such as how many symptoms should be apparent. These are called operational diagnostic criteria. For example, the diagnosis of bipolar depression requires the presence of an elevated mood, plus 3 additional symptoms, during the manic phase. The patient should also have experienced episodes of depression. A second method of classification in use in the UK today is a manual published by the World Health Organization, WHO. It is known as the International Classification of Diseases, Injuries and Causes of Death, ICD, and contains a comprehensive listing of all diseases. A section on mental health problems was first included in the ICD in 1948 and has been periodically updated. This Sect lists 10 major categories of mental disorders and their operational diagnostic criteria. DSM-IV has 16 categories of mental disorders. The difference occurs because the ICD uses a smaller number of general categories. For example, the ICD has one category to cover neurotic, stress-related and somatoform disorders, whereas the DSM lists these as separate categories. In one instance, however, disorders of childhood, the ICD has 3 specific categories, whereas the DSM uses a general description. The difference in categories and the more precise way that disorders have been categorized in DSM-IV has led to claims that it is more reliable than ICD. Some experts have claimed that systems of classification are needed to help communication about the nature of the patient's problems. It helps mental health professionals decide which treatment to offer and make predictions about recovery. The system also enables research to be undertaken with comparable groups of patients, which can help develop and improve treatment methods. The major categories of mental disorder as identified by DSM-IV are as follows. Delirium, dementia, amnesia and other cognitive disorders. These are the organic mental disorders, known to have a definable physical cause such as brain disease. Schizophrenic and other psychotic disorders, serious mental disorders where the individual loses touch with reality. Substance-related disorders, addiction to alcohol, opiates, cocaine, amphetamines or other substances causing serious behavioral problems. Mood disorders, depressive symptoms or mood swings from excessive highs to extreme lows. Anxiety disorders, any disorder where the individual feels very anxious, such as phobias and obsessive-compulsive disorder. Somatoform disorders, a history of physical complaints without any obvious physical cause, for example, hypochondria. Dissociative disorders, a sudden alteration in consciousness affecting memory and identity, for example, total memory loss, non-organic. Adjustment disorders, the development of major emotional or behavioral symptoms following a stressful life event. Disorders usually diagnosed in infancy, childhood or adolescence, intellectual, physical or emotional disorders usually, beginning early in life, such as autism and attention deficit disorder. Personality disorders, inflexible and maladaptive patterns of adult behavior. There are 10 disorders listed, including antisocial personality disorder. Sexual and gender identity disorders, unconventional sexual gratification, sexual dysfunction and gender identity disorders. Impulse control disorders, the person's behavior is inappropriate and out of control, for example kleptomania, repeated stealing without any monetary need. Factitious disorders, people who intentionally produce physical illness because of the need to assume a sick role. Sleep disorders, sleep is disturbed, either too much or too little, or unusual events occur during sleep, such as sleepwalking. Eating disorders, anorexia nervosa, where the person avoids eating, or bulimia nervosa, where binge eating is followed by purging. Other conditions that may be a focus of clinical attention, psychological factors that may affect the physical condition of a person such as marital or work-related difficulties. The signs and symptoms of bipolar disorder as listed in DSM-IV. 1. Depressive phase. SAD, depressed mood, manic phase. Increase in activity at work, socially and sexually. 2. Depressive phase. Loss of interest and pleasure in usual activities. Manic phase, unusual talkativeness and rapid speech. 3. Depressive phase. Difficulties in sleeping, disturbance in sleep patterns or sleeping for long periods. Manic phase, less than the usual amount of sleep required. 4. Depressive phase. Shift in activity level, becoming lethargic, drowsy, or agitated. Manic phase, flight of ideas or subjective impression that thoughts are racing. 5. Depressive phase. Poor appetite and weight loss, or increased appetite and weight gain. Manic phase, inflated self-esteem, belief one has special powers, talents and abilities. 6. Depressive phase. Loss of energy, great fatigue. Manic phase, distractibility, attention easily diverted. 7. Depressive phase. Negative self-concept, self-reproach, self-blame, feelings of guilt and worthlessness. Manic phase, over-involvement in activities with negative consequences, e.g. reckless spending. The major categories of mental disorder identified in ICD-10 compared to DSM-4-1. Organic, including symptomatic mental disorders. Similar to schizophrenia, schizotypal and delusional disorders. Similar 3. Mental and behavioral disorders due to substance abuse. Similar 4. Mood, affective disorders. Similar 5. Neurotic, stress-related and somatoform disorders. Split into 4 categories: anxiety, somatoform, dissociative and adjustment disorders. 6. Behavioral and emotional disorders with onset in childhood. 6, 7 and 8 in ICD are grouped under one category in DSM-7. Disorders of psychological development. 8. Mental retardation. 9. Disorders of adult personality and behavior. Similar 10. Behavioral syndromes, physiological disturbances and physical factors. Split into 2 categories, sleep and eating disorders, in DSM-11. Unspecified mental disorder. Similar. Both DSM and ICD group together symptoms in categories. Psychiatrists look for symptoms and make a decision about whether a person has a mental disorder or not. The classification system therefore has the same limitation as a closed questionnaire. A yes or no decision must be made. Pilgrim, 2000, argued that the difference between mental health and mental abnormality is a matter of degree. For example, most people experience depression. The severe ity of the condition is a more important indicator of mental disorder. A dimensional classification system would measure the patient on a ranked scale rather than simply ticking off the number of symptoms seen. Axes 4 and 5 in the DSM do use a dimensional classification system, however these axes are currently optional during diagnosis. Interestingly, neither system actually uses the term mental illness, opting instead to describe mental disorders. Cooper, 1994, argued that there is little evidence so far that many psychiatric diagnoses are caused by physiology. For example, there is still great debate about the causes of illnesses, such as schizophrenia or depression. The use of the term disorder neatly avoids the need to debate the meaning or value of the medical model.